So I'm going to talk about the rational use of inotropes and vasopressors in the shock. As we know, a shock is a common presentation in the ICU, and there are a lot of vasoactive agents that are available to treat the shock. So it's quite possible that we may get confused which drug should be used in which condition. So let me try to simplify this and hope it will help in our clinical practice. So shock basically is a life-threatening state of circulatory failure leading to inadequate tissue perfusion, which leads to cellular dysfunction and organ failure. Early use of vasoactive drug is essential to restore the perfusion. The objective of this topic is to understand the shock physiology, to review the vasopressors and inotropes, learn the rational drug selection, understand the drug doses and monitoring, and apply the guideline-based management for treating the shock. Definition of the shock: acute circulatory failure leading to inadequate oxygen delivery to tissue. That is basically a failure to meet the metabolic demand of the tissue. And the clinical feature includes hypotension, that is systolic blood pressure less than 90, then elevated lactate level, and organ dysfunction. This organ dysfunction can vary from the earliest sign may be cold finger or cold extremities. Then you get the tachycardia, hypotension, tachyapnea, and the last is the altered mental status. So these are all the clinical signs of the hypoperfusion. As per the shock wheel classification, wheel and shooting classification, the shock is classified into 4 types. Hypovolemic, that is, for example, because of the trauma, blood loss, burns because of the third spacing, diabetic ketoacidosis because of water loss in the urine. Then cardiogenic, like myocardial infarction, valvular heart disease, cardiomyopathies, arrhythmias, and myocarditis. In myocardial infarction, if more than 40% of the myocardium is involved, majority of these patients will develop cardiogenic shock. Then third type of the shock is distributive, which is basically a vasodilatory shock. Distributive shock types are septic shock, that is because of the infection. Then neurogenic shock because of the spinal cord injury. Anaphylactic shock because of the allergy and the adrenal insufficiency. And the fourth type of shock is obstructive shock, that is the, for example, pulmonary embolism, tension pneumothorax, cardiac tamponade, even aortic dissection is a type of obstructive shock. The two basic pathophysiology of the shock is, one is the reduced cardiac output and the second is reduced systemic vascular resistance. So in majority of the shock, both of these can be present, and this leads to the impaired oxygen delivery, cellular hypoxia, lactic acidosis, and finally organ dysfunction if left untreated. Goals of our hemodynamic resuscitation are mean arterial pressure more than 65, adequate urine output that is more than 0.5 to 1 ml per kg per hour, then improved mental status, capillary return time, a simple bedside test where you can see after pressing the nail, if the pink color returns within the 3 seconds, that is suggest an adequate tissue perfusion. It is a very simple bedside test. Then decreasing lactate on subsequent ABG and the evidence of adequate organ perfusion. Mean arterial pressure, many studies have seen. See, mean arterial pressure, people have studied 60 millimeter, 65 millimeter, 70 millimeter, 75 millimeter as a target. But majority of the studies suggest MEP of 65 is more or less enough for the tissue perfusion in majority of the patients. Vasoactive drugs, there are basically 2 major groups. One is the vasopressors, which increases the vascular tone. The examples are adrenaline, dopamine, norepinephrine, and vasopressin. And inotropes are the one which increases the myocardial contractility, like Dobutamine, Milrinone, and Levosimendan. They act to the receptors. So alpha-1 receptor, which are present in the blood vessels, causes the vasoconstriction. Beta-1 receptors are present in heart, which leads to increase in heart rate and cardiac contractility. Beta-2 receptors are present in the blood vessels and in the bronchosis, causing vasodilatation and bronchodilation. These receptors are there through which the vasopressin act, and there are some dopamine receptors also, especially in the splanchnic and renal circulation, where it causes the splanchnic and renal vasodilatation. Now coming to our first and the oldest vasopressor, that is epinephrine. So epinephrine actually has got a mixed action. It has got mixed alpha as well as the beta agonist action. It increases the cardiac output, also increases the systemic vascular resistance, and also causes the splanchnic and renal vasoconstriction. There are a lot of metabolic effects also associated with epinephrine, like increased glucose level, which occurs because of the alpha receptor stimulation. This results in the inhibition of insulin secretion, and that is why the glucose level increases. Also, it causes the increase in lactate level because of the beta receptor stimulation, which causes the lipolysis and glycolysis, and that lead to the lactic acidosis. So, when the patient is on adrenaline, increase in lactate is expected, though it is mild to moderate, not very high, and it is not because of the tissue hypoxia. It can be a metabolic side effect of a epinephrine. Epinephrine is primarily used in the cardiopulmonary resuscitation in cardiac arrest, and it is a drug of choice in anaphylactic shock. It is used as a third-line agent after noradrenaline, after the noradrenaline and vasopressin in septic shock. It's used for hemodynamic support post-operative CABG patients also, and it is as effective as any other catecholamine, but side effects like arrhythmias, metabolic side effect, and increased oxygen consumption in patient with CAD limits its popularity in the septic shock. The second drug, dopamine, is basically a feel-good neurotransmitter, and in periphery, it causes the dose-dependent effect on the as a vasopressor as well as inotropic effect. In the low dose, it acts on the dopamine receptor, resulting in vasodilatation in splanchnic and renal bed, which results in the increase in the urine output. In moderate doses, 3 to 10 mics per kg per minute, it causes both beta 1 and beta 2 stimulation, which increase the cardiac contractility, also increases the heart rate, and it causes some vasodilatation. In more than 10 mics per kg per minute, it has a predominant alpha 1 receptor action, resulting in systemic and the pulmonary vasoconstrictions. Uses. So, dopamine is primarily used, now its use is very limited. It is used where there is a shock with bradycardia. For example, if there is an inferior myocardial infarction with EV dissociation, or if there is a spinal cord contusion where there is a shock with bradycardia because of the innervation of sympathetic nerves. In those cases, we use dopamine. Otherwise, its role in septic shock and in other conditions is very, very limited. As we know, in septic shock, the norepinephrine now is a preferred agent and drug of choice. Also, previously, we used to use dopamine in the low dose to prevent or treat the acute renal failure, but now there is no role and it is not recommended to treat ARF or to prevent the renal hypoperfusion. So, this adrenaline and dopamine, they are our all-rounder. They can increase the cardiac contractility, they can cause the vasoconstriction. So, all-rounder in a game of cricket is always appreciated. But in a game of shock, we need specialist. So, we come to our specialist, that is a norepinephrine. Norepinephrine is a energy neurotransmitter. It increases the energy, it increases the alertness in the brain. In periphery, it has got a strong alpha 1 vasoconstriction effect and a weak beta 1 stimulation. So it improves the mean arterial pressure with mild increase in cardiac contractility without increasing the heart rate. And that is why the maximum benefits of the norepinephrine is because of this effect, that it doesn't increase the tachycardia. Normally, it causes the splanchnic and renal vasoconstriction, but in septic shock where there is an abnormal vasodilatation, paradoxically it improves the renal blood flow. It is the first line vasopressor in septic shock and now even in cardiogenic shock. So there are very few studies which directly compare the first line vasopressor norepinephrine versus dopamine in shock. And this study, SOAP2 study published in NEJM 2010, the results were overall 28-day mortality, there was no difference. But in a subgroup analysis in cardiogenic shock, it was found that the mortality was higher in dopamine group, probably because of the increased side effect of the dopamine, especially the arrhythmias. Then another specialist is the vasopressin. It acts on the V1 receptor and is pure vasoconstrictor. It is used in vasodilatory shock like septic, anaphylactic, autonomic insufficiency following spinal anesthesia. It is also used in a bolus form in cardiac arrest. It is used as an adjuvant therapy in septic shock. It helps reduce the catecholamine requirement. So some septic patient may have a vasopressin deficiency, and even if you go on increasing the norepinephrine dose, the patient may not respond. In those cases, when escalating doses of norepinephrine is not working, adding vasopressin majority of the time helps. The popular dose is 0.03 unit per minute. Because of the V2 receptor stimulation, it can cause water retention and hyponatremia. Phenylephrine is again a pure alpha 1 agonist. It causes the strong vasoconstriction, and because of the hypertension, it can cause reflex bradycardia also. It is primarily used in hypotension during spinal anesthesia because it can be given as bolus therapy also. And where there is a stenotic pressure, valve disease like aortic stenosis or HOCM, where you do not want to increase the heart rate and wants to maintain the mean arterial pressure, it is used as a continuous infusion. As it causes the increase in mean arterial pressure, there is no increase in the gradient across the aortic wall, and that is why it is used in the treatment of shock in patient with aortic stenosis or HOCM. It is also useful in treating the shock caused by simultaneous use of sildenafil and the nitrates. Now, inotropes, they increases the myocardial contractility and they improve the cardiac output and the tissue perfusion, and they're typically used when the patient is having the left ventricular dysfunction. Dobutamine is the most common inotropic agent that we use. It has got a beta 1 agonist and a weak beta 2 agonist in the ratio of 3:1. It increases the cardiac contractility and cardiac output with the peripheral vasodilatation. It is used in cardiogenic shock with preserved BP. So if the BP is say 80, 90, 100, we can start with low dose of dobutamine. It is also used in treating the decompensated heart failure because it increases the cardiac contractility and also decreases the afterload. And in septic myocardial depression, it is used in combination with the norepinephrine. It should be avoided in the stenotic lesion like aortic stenosis or HOCM mitral stenosis, as it can increase the gradient. Milrinone is another inotropic agent which is used. It is a phosphodiesterase 3 inhibitor. So if it is not dependent upon the adrenergic receptors, it increases the cardiac contractility comparable to dobutamine, has a better pulmonary vasodilatation, but is more likely to cause the hypotension compared to dobutamine. It is used in acute heart failure after cardiac surgery, and it is also used in weaning the high-risk patient on cardiopulmonary bypass. There is one study which compared dobutamine and milrinone, that is known as DOREMI trial, and they found that there is no significant difference in mortality outcome. But dobutamine is a short-acting, half-life is 2 minutes, and therefore it is preferred for rapid hemodynamic stabilization, and it is also preferred in renal failure because it doesn't require the dose adjustment. While the milrinone is obviously avoided or you need a dose modification in renal failure, milrinone has a longer half-life and has a slower but a prolonged action, and therefore it is preferred for longer hemodynamic stabilization. For example, the patients who are waiting for heart transplant. Also, it has got a better pulmonary vasodilatation. So, where we need a reduction in the pulmonary vascular resistance, we can prefer it over the dobutamine. Example is for example, in right heart failure. And if patient is on beta blocker, then definitely dobutamine will not work. And in that condition, we have to use the milrinone. Levosimendan is another good novel agent. It has a cardiac biofilament calcium sensitizer, and it improves the myocardial contractility without increasing the myocardial ATP consumption. So it improves the myocardial contractility at a low energy cost. It also improves the diastolic relaxation and causes vasodilatation, and it is used in decompensated heart failure and cardiogenic shock without the hypotension in selected patient. But nowadays it is not available. The common vasopressor doses is shown in this slide. So norepinephrine from 0.5 to 1 mics per kg per minute. It is a first-line treatment in septic shock. Epinephrine is a first-line treatment in the anaphylaxis and cardiac arrest. Vasopressin is used as an adjuvant therapy in septic shock, and phenylephrine is used in selected hypotension like spinal anesthesia or in stenotic lesions. Dobutamine, it is predominantly primarily used in decompensated heart failure, cardiogenic shock, septic myocardial depression. Milrinone, as we already discussed, where we can prefer it over the dobutamine, and the dopamine has a very limited role nowadays. Drug selection by shock type. In septic shock, norepinephrine is the first line agent. In cardiogenic shock, dobutamine primarily, but if patient is having hypotension, especially if the blood pressure is less than 70 or 80 systolic, then first use norepinephrine, stabilize the blood pressure, and then add dobutamine to improve the cardiac output. In hypovolemic shock, obviously, fluid has to be used first and pressure only after the fluid resuscitation, because if we use early vasopressor in hypovolemic shock, it increases the mortality. In neurogenic shock, norepinephrine is the drug of choice as it maintains the vascular tone. Sometimes if there is bradycardia, you can use dopamine or epinephrine. So all those patients, there is a strong recommendation when the patient is on the vasopressor or inotrope. Continuous blood pressure monitoring using an arterial BP line is definitely indicated. We can monitor the urine output hourly and lactate level in subsequent ABG, whether it is decreasing or not. Cardiac output monitoring using pulmonary catheter or flow tag is sometimes used when there is a mixed shock. For example, if there is a combined septic and cardiogenic shock, or if cardiogenic shock is very severe and you want to assess whether fluid therapy is going to help. In those conditions, we can use the pulmonary catheter to measure the cardiac output and systemic vascular resistance. Our target during the therapy, as we already discussed, mean arterial pressure should be more than 65 millimeter. urine output should be 0.5 to 1 ml per kg per hour, improving lactate level, and clinical evidence of adequate tissue perfusion. You can use the capillary return time also. Now, adverse effect of the vasopressors, and for that matter, inotrope, all of them can cause arrhythmias. They can cause increased oxygen consumption of myocardium and lead to the myocardial ischemia. It can cause peripheral ischemia in higher doses, and extravasation injury can be sometimes troublesome. It can cause extensive necrosis. Now, for principles of our drug use, first is always correct hypovolemia, especially in hypovolemic shock like traumatic shock or septic shock. Then the drug based on the physiology, whether you want to increase the cardiac output or whether you want the vasopressor. Then always start with low dose and titrate, because all these have very short half-life and minute to minute action. If you have arterial line in the place, you can easily titrate the doses, and higher doses have been shown to increase the mortality, and we need a very close monitoring when you are using the inotropes or vasopressors. Clinical pulse, norepinephrine is the first line in the septic shock, and now also in cardiogenic shock if the BP is less than 70 systolic. If the BP is 80, 90, 100, closer to 100, we first use the dobutamine. In cardiac arrest and anaphylaxis, epinephrine is the drug of choice. Vasopressin is used as a second line agent if there is a poor response to norepinephrine. Combination therapy is often required, especially in cardiogenic shock, and continuous monitoring improves the outcome. So, in conclusion, rational use of vasoactive drugs improves the survival in the shock, especially in the septic anaphylactic shock. We see immediate results and work as a bridge till the coronary intervention is done. Thank you very much.